Good day, my dears. From today, we start a cycle of lectures according to the inflammatory diseases of oral and maxillofacial area. And the first lecture is about furuncle, carbuncle of the face, etiology, pathogenesis, clinical features, diagnosis, and treatment. The next part will be about one of the most difficult complication of furuncle and carbuncles of the face, that is a cavernous sinus thrombosis and erysipelas of the face. And let's start. What are they? Hair follicles can become inflamed by physical injury, chemical irritation, or infection that leads to folliculitis. Classification is by the depth of the involvement of the hair follicle. The most common form is superficial folliculitis that manifests as a tender or painless pustule that heals without any scarring. The hair shaft will frequently be seen in the center of the pustule. Multiple or single lesions can appear on any skin-bearing hair, including head, face, neck, trunk, buttocks, and extremities. Associated systemic symptoms as a fever rarely exist, and Staphylococcus aureus is the most likely pathogen. However, commensal organisms such as yeast and fungi occasionally appear, especially in immunocompromised patients. These lesions typically resolve spontaneously. Typical therapy with erythromycin, clindamycin, or mupirocin or benzoyl peroxide can be administered to accelerate the healing of the process. Staphylococcus will occasionally invade the deeper portion of the follicle, causing swelling and erythema with or without pustule at the skin surface. These lesions are painful and may scar. This inflammation of the entire follicle or deeper portion of the hair follicle or isthmus or below is called deep folliculitis and can be as a furuncle of the skin. Folliculitis may be treated with topical therapy or antibacterial washes. And topical antibiotics such as bacitracin, mupirocin, ritapamulin ointment, and topical clindamycin are topical antistaphylococcal antibiotics. In addition to treating the individual's pustules, benzoyl peroxide washes, dilute sodium hypochlorite bars, and chlorhexidine washes are antimicrobials that can be helpful to decolonize the skin surface. Skin surface staphylococcal carriage is in abrasions and ecchymatous areas may be addressed with these topical antibiotics, topical chlorhexidine washes, or dilute sodium hypochlorite bath. Mupirocin ointment applied on the anterior nares daily for 5 days long with beach baths may help prevent recurrence of this pathology. Furuncles and carbuncles. Furuncles or boils, they are cutaneous abscess that begin in the skin glands and hair follicles, and usually they are the only inflamed part of the face or submandibular area, as you can see on this slide, or other follicular-bearing surfaces of the body. Carbuncles is a deep-seated mass of fistulous tracts between infected hair follicles, and as you can see, carbuncle is several furuncles which are lined together, and we can see them as an inflamed area bigger than due to the furuncles. And let's see what are they. So once more, furuncle is an infection of the hair follicle that extends into surrounding skin and deeply underlying subcutaneous tissue, and carbuncle is contiguous collection of 2 or more furuncles. They typically present as erythematous, tender, inflamed, fluctuant nodules with multiple draining sinus tracts or pustules on the surface, and you can see on the picture, on the photo, furuncles of the face. Systemic symptoms are usually present and regional lymphadenopathy may occur. They can arise in any hair-bearing location of the body, and however, they are most common in areas with thicker skin such as face, nose, ears, posterior neck, back, and other parts of the body. Carbuncle can start as a folliculitis, which is left untreated, can lead to a furuncle, and when multiple furuncles are contiguous, it becomes classified as a carbuncle. Carbuncles can be solitary or multiple. Bacterial infection within the hair follicle causes carbuncle or furuncle. The most common causative organism is Staphylococcus aureus and frequently involves methicillin-resistant Staphylococcus aureus. And be attentive that methicillin-resistant Staphylococcus aureus, in short, we can name MRSA. Occasionally, carbuncles and furuncles can be caused by anaerobic bacteria, especially in cases that are recurrent. Staphylococcus aureus can normally be found on intact skin, most commonly in interregional areas such as the groin, axilla, buttocks, and neck. It can also be present in nails. Staphylococcus aureus can be transformed to other anatomical locations by scratching. When the skin barrier is broken down or disrupted, bacteria can inoculate the hair follicle. Once inoculated, the bacteria can proliferate and lead to folliculitis, furuncle, and/or carbuncle. The incidence of carbuncles is uncertain, however, they are considered relatively common. They are most often found in young to middle-aged adults, being uncommon to early childhood. Carbuncles are known to affect males more than females. Maybe the reason of this is hygiene of the skin and the thickness of the skin. Predisposing conditions that lead to a compromised or broken down skin barrier include eczema, diabetes mellitus, alcohol use disorders, malnutrition, immunodeficiency, obesity, poor hygiene. Other predisposing factors include chronic methicillin-resistant Staphylococcus aureus colonization, living in crowded conditions, hyperhidrosis, and anemia. A patient presenting with a carbuncle typically provides a history of slowly enlarging tender nodule. The patient may state that it started as a pimple or pustule that they tried to pop. However, over several days to 2 weeks, the lesion grew progressively larger and became tender and fluctuant. And I hope that you remember what is a fluctuation or fluctuant. And this symptom we can palpate if inside the soft tissue there are pus collection. How can we palpate this symptom? Only by bimanual palpation. So both hands should be applied on the area which is inflamed and the edema. We can find the edematous tissues and then gently palpate or press by one hand, fingers of one hand, and by fingers in on other hand, we can feel this movement of some liquid part inside these soft tissues. So that is a symptom of fluctuation. Carbuncles are known to cause systemic symptoms, however, this is not mandatory for the diagnosis. Systemic symptoms may include regional lymphadenopathy, fever, fatigue, and malaise. Carbuncle classically presents as a red erythematous painful nodule with multiple overlying pustules. Frequently, the pustules rupture due to the minor trauma, friction, or pressure, which can create an overlying hematogenous crust. Anatomically, carbuncles are associated with the hair follicle and thus can occur at any hair-bearing surface, as well as furuncles, of course. However, there is a strong predilection for the nape of the face, neck, back, buttocks, axle, and groin. Carbuncle diagnosis is typically made based on physical examination findings, and when furuncle or carbuncle are suspected, it is important to obtain a bacterial culture and sensitivity from the purulent fluid within this inflammation. The bacterial swab must be taken before the initiation of antibiotics. The bacterial culture and sensitivities are important in guiding antibiotic therapy and to rule out MRSA or any gram-negative bacteria as the causative agents. If systemic symptoms are present, a complete blood count may be obtained. Additionally, if the patient is diabetic or suspected to have diabetes, hemoglobin A or fasting glucose can be obtained. And in this slide, you can see management of treatment. And okay, let's talk about it. And the next slide, I'll show you culturing and sensitivity test. How do we do it? How can we understand which one is antibiotic of choice? Furuncles and carbuncles typically require medical and surgical interventions, and carbuncles and furuncles are usually incised and drained in office and under local anesthesia. The incision is usually performed with a scalpel blade. We can use different scalpels, but usually we use 11th number, curette, and the iodoform packing strips. The blade is used to make the incision into the furuncle or carbuncle cavity, and pressure is manually applied to express the purulent materials within. Bacterial culture and sensitivity are usually obtained from the purulent material at the next step. Next, a curette or a hemostat is used to break up any loculation that may be present, and another attempt to express material is made. Once a majority of purulent material has been expelled, the lesion is typically packed with iodoform strips or gauze to assist with the further drainage. The packing is typically left in place for 24 or 48 hours and then removed. Of course, removing of drainage or packing, as we name it in here, uh, can be done only after the symptoms reduce. What symptoms? Of course, all symptoms of inflammation such as pain, swelling, hyperemia, and local fever. After incision and drainage, oral antibiotics are typically initiated, and this is particularly important if the patient has any systemic symptoms or if there is any surrounding cellulitis. Common first-line oral antibiotics include dicloxyphylline and cephalosporins. If MRCA is suspected or cultured, oral antibiotics as clindamycin, tetracyclines, linezolid, or glycopeptide may be used. Oral antibiotics can be further adjusted once bacterial culture sensitivities are known. Topical antibiotics such as clindamycin or mipiracin may be used as adjunctive therapy. Once the carbuncle has receded, it usually does not require further treatment. However, in recurrent or refractory cases, the lesion may need to be surgically excised. In patients with recurrent carbuncles and furuncles, prophylactic measures may be taken, and this includes having patients bath with benzyl peroxide wash or antibacterial soap. So, and as I said, let's look at this slide and where we can see bacterial culture and sensitivity test. We should use this right after incision during the draining the pars. We have special sterile swabs, and we insert these swabs inside the pus and then send to the microbiological investigation and culture. What does it mean bacterial culture. That means that on some nourishment agents or agar-agar, for example, we can put this pus, and bacteria which are inside the pus start growing, and we can see different colonies of the bacteria in this nutrient medium, and then we have different bottles with different antibiotics, and we put a drop, only a drop of different antibiotics to different culturing or different growing cultures, and see if the zone of inhibition is big enough, so that means that there is no growth, and this antibiotic can be like antibiotic of choice. Of course, this culturing and sensitivity test takes a lot of time, not more than 5 and even 7 days, and that doesn't mean that our patient will stay without any antibiotics. Of course, we have to prescribe antibiotics right after our surgical treatment, incision and drainage. So that means that we have to prescribe broad spectrum antibiotics for the patient, and only after sensitivity test will be ready, we can see if it is needed to change antibiotic, we can do it. But in this period, I hope that most of patients will be treated and will be healthy, and no need of different antibiotics or changing of antibiotics is needed. The differentiation diagnosis for carbuncle and furuncle includes cystic acne, hidradenitis suppurativa, cellulitis, osteomyelitis, ORF, anthrax, and arthropod bite. Cystic acne lesions are typically similar than furuncles and carbuncles and have the only pustule, if any, on the surface. Hidradenitis suppurativa usually only present in the axilla and groin regions and is more chronic. Cellulitis typically does not have any pustules and is not nodular. Osteomyelitis is more common overlying a joint and may be ruled out with imaging such as MRI or CT. And I hope you remember that osteomyelitis, that is inflammation of the bone, and symptoms, pathognomic or specific symptoms of osteomyelitis is quite different. ORF is a self-limited viral infection and classically goes through 6 stages: umbilicated, targetoid, weeping nodule, regenerative, papillomatous, and regressive. Additionally, ORF usually occurs in those handling sheep or other farm animals. Cutaneous anthrax typically involves farm animals or bioterrorist exposure, for example, and cutaneous anthrax lesions classically develop an overlying black egg heart. Arthropod bites usually occur in multiples and won't be more acute than furuncles and carbuncles. So, you have to find any connection between different diagnoses and furuncles and carbuncles, and truly to say that is not difficult to diagnose furuncle or carbuncle, because they are so specific, they have such a specific visual examination that we can easily diagnose it. So, furuncles and carbuncles develop over several days to several weeks, reaching a diameter of 2 to 10 centimeters. After approximately 1 week, multiple pustules, if it is carbuncle, or one pustule, if it is furuncle, develop and protrude from the surface. The lesion drains a serosanguinous fluid. Healing occurs over several weeks and will result in a scar. Rarely, if left untreated, mortality can occur from sepsis or diabetic ketoacidosis in those with comorbid conditions or immunosuppression. With proper treatment, carbuncles are cured, and the prognosis is excellent, resulting in only a cosmetic scar. Potential complications from carbuncles and furuncles include septicemia, cavernous sinus thrombophlebitis, and scar. Other complications that may occur from carbuncle treatment include allergic response to antibiotic therapy, bleeding, or nerve damage and scar formation. And what about cavernous sinus thrombosis? That will be the next part of this lecture, and why I decide to give you this information, because furuncles and carbuncles can be treated easily in outpatient management for the patient. But in some cases, when that is a danger triangle or triangle which includes nose, lips, and chin, if in this area carbuncle or furuncle occurs, that means that it can cause or it may lead to such complication as a cavernous sinus thrombosis, because there is an anatomical connection between veins of superficial veins of this area and cavernous sinus. So this patient, even with a small furuncle, is even without any difficulties and without any common symptoms of this disease, inflammatory diseases of maxillofacial area, should be treated in inpatient management. So, face and neck, except danger triangle, which is nose, nasolabial folds, lips, and chin, that is simple furuncles and carbuncles in most cases. Of course, they can occur inside nose, inside ears, and can cause any complications according to these areas, but the most difficult complication, like a cavernous sinus thrombosis, a life-threatening condition, which should be immediately diagnosed, this patient should be treated in inpatient management. So let's start talking about cavernous sinus thrombosis. What is it? This complication is usually septic, but can also be aseptic. Septic causes can follow central facial infection, especially within the danger triangle of the face. And as I explained earlier, from the corners of the mouth to the bridge of the nose. These include abscess of cellulitis, furuncles and carbuncles, sinusitis, especially sphenoiditis and ethmoiditis, dental infections, extractions, or procedures, even a posterior superior alveolar nerve block entering the pterygoid plexus, maxillofacial surgery, otitis media, and mastoiditis. Aseptic causes are less common than septic causes, and these include trauma, surgery, or pregnancy. A variety of infection organisms can cause cavernous sinus thrombosis, also the majority are bacterial. Staphylococcus aureus may account for two-thirds of cases, and methicillin resistance should be considered. Other typical organisms include Streptococcus species, approximately 20% of cases, pneumococcus, gram-negative species such as Proteus, Haemophilus, Pseudomonas, Fusobacterium, bacteroids, as well as gram-positive species such as Corynebacterium and Actinomyces. Several of these, for example, bacteroids, Actinomyces, and Fusobacteriums, are anaerobic. Fungal infection is cavernous sinus thrombosis is less common, but it can include aspergillus, that is most common, zygomycosis such as mucormycosis or coccidiomycosis in immunocompromised individuals. Rare precipitants of cavernous sinus thrombosis can include parasites such as toxoplasmosis, malaria, and trichinosis, as well as viral causes such as herpes simplex, cytomegalovirus, measles, hepatitis, and human immunodeficiency virus. Immunosuppression, such as uncontrolled diabetes, steroid use, cancer, or chemotherapy, may be a risk for not only developing cavernous sinus thrombosis but also developing complications. The biggest risk factor are facial infections, acute sinusitis, and periorbital infections. Thrombophilia is a significant risk factor for cavernous sinus thrombosis. Women who are pregnant, postpartum, or receiving oral contraceptives or hormone replacement therapy may be at risk or increased risk. A variety of thrombophilic genetic disorders may lead to cavernous sinus thrombosis, and these include factor V Leiden mutation, prothrombin mutation, and antithrombin 3 protein C or S deficiency or increased factor VIII. Acquired disorders such as antiphospholipid antibody syndrome, hyperhomocystinemia, heparin-induced thrombocytopenia, and obesity could also contribute to cavernous sinus thrombosis risk. Other risk factors for thrombosis include severe dehydration, such as in hyposmolar, non-keratotic state, nephrotic syndrome, and sickle cell disease. And let's see, or let's look at this slide on cavernous sinus anatomy, where we can find these cavernous sinuses. The cavernous sinuses, one on each side of the sella turcica, and they are above the and lateral to the sphenoid sinuses, anteriorly superior orbital fissure, and posteriorly petrous part of the temporal lobe. Are trabeculated cavernous spaces created by layers of dura mater and filled with venous blood. This blood drains the superior and inferior ophthalmical veins and superficial cortical veins anteriorly, and then drains into the basilar plexus posteriorly via the superior and inferior posterior sinuses. The cavernous sinus has been coined as an anatomic jewel box because it shares an intimate relationship with the several important structures. Within the lumen of these cavernous sinuses, pass the horizontal segment of the internal carotid artery, the sympathetic plexus, and cranial nerve 6 abducens medially. Whereas the outer layers of the lateral wall of the carotid sinus are transverted by cranial nerves 3, that is oculomotor 5, the first and second branches ophthalmic and maxillary, of the trigeminal nerve, and 4. Trochlea. Once more, septic cavernous sinus thrombosis occurs from the local spread, often from the bulbous facial and ophthalmic veins. Adjacent infections such as the sinusitis are possibly the most common case, especially spheniditis and ethmoiditis. Facial carbuncles and furuncles, or facial cellulitis or abscess, especially within the danger triangles of the face formed by the corners of the mouth and bridge of the nose. Periorbital and orbital cellulitis, pharyngitis, tonsillitis, otitis media, mastoiditis, and even dental infections. The mechanism is due to embolization of the bacteria and other infection organisms which trigger thrombosis, which then can trap infection within the cavernous sinus. And pay attention in here. In nowadays, COVID virus is the virus which causes thrombosis. And of course, in this case, as post-COVID infection, carbuncles and furuncles may occur, and the next stage as a complication, cavernous sinus thrombosis may occur as a complication of this situation. So, you as doctors should be very attentive to the patient and should know how to diagnose this complication or this situation, and then, of course, treat them. Cavernous sinus thrombosis leads to decreased drainage from the facial vein and superior and inferior ophthalmic veins, resulting in facial and periorbital edema, ptosis, proptosis, hemosis, discomfort, and pain with eye muscle movement, papilledema, retinal venous distension, and loss of vision. Lack of valves, the dural sinus systems, allows follow through the emissary veins into and out of the cavernous sinus, and thrombus can propagate into the dural system. Also, communication between the right and left cavernous sinus via the intercavernous sinuses anterior and posterior to the sella turcica allow the spread of thrombus and infection from one side to another. Local compression, and let's see the slide. Local compression and inflammation of the cranial nerves can lead to the several partial or complete cranial neuropathies, including diplopia from partial or complete external ophthalmoplegia due to compression of the sixth abducens, third oculomotor, and fourth trochlear nerves. Limited eye abduction from abducens palsy is the most common early finding, often progressing to inability to move the eye in any direction when a third, fourth, and sixth are involved. Internal ophthalmoplegia, non-reactive pupil, occurs from loss of the sympathetic fibers for the short ciliary nerves, resulting in miosis, and or from loss of parasympathetic fibers from cranial nerve 3, resulting in mydriasis. Numbers of paresthesias around the eyes, nose, and forehead, and loss of corneal blink reflect from the ophthalmic nerve, a branch of the trigeminal nerve. Facial pain, paresthesias or numbness from the compression of the maxillary branch of the trigeminal nerve. Septic cavernous venous thrombosis can result in the central nervous system or infectious pulmonary complications. Because of the dural virus, venous and cavernous systemic is valveless, this venous blood can communicate with the dural sinuses and cerebral and emissary veins, leading to meningitis, dural empyema, or brain abscess. Infection can spread via the jugular vein to the pulmonary vascularity, resulting in the septic emboli or abscess, pneumonia, or empyema. Stroke can occur following carotid artery narrowing, vasculitis, or hemorrhagic infection following progress into cortical vein thrombosis. Hyperpatriotism can occur due to ischemia or the direct spread of infection. Patients with cavernous sinus thrombosis most commonly complain on fever, headache, periorbital swelling and pain, vision changes such as photophobia, diplopia, loss of vision. Symptoms may be present at onset on the progress subacutely over days. Usually it starts with one eye and then progresses to another eye. Less common symptoms may include rigors, stiff neck, facial numbness, confusion, seizures, stroke symptoms, or even coma. Vital signs may reveal fever, sometimes in a picket fence pattern characteristics for septic thrombophlebitis, tachycardia, or hypertension. Neurologic findings such as altered mentation, lethargy, or obtundation are not usual. Seizures of stroke syndrome such as hemiparesis are rare. Eye findings are nearly universal, and It takes more than 90% of cases. This include periorbital edema, initially unilateral but typically bilateral, lead erythema, hemosis, ptosis, proptosis due to impaired venous drainage of the orbit, restricted or painful eye movement, and less common papilledema, retinal hemorrhages, decreased visual activity, and photophobia. In some cases, diminished papillary reflex and pulsated conjunctiva can be observed. Blindness can result in 8 to 15% of cases. Individually, a sixth cranial neuropathy is the most common neurotrophy, resulting in partial ophthalmoplegia with limited eye abduction. Most cases, however, progress rapidly to complete external ophthalmoplegia from third, fourth, and sixth cranial neuropathy. And let's see the next slide. Internal ophthalmoplegia results in non-reactive pupil from the paralysis of the iris and ciliary body, either constricted or miosis from loss of systemic fibers from the short ciliary nerves, or dilated mydriasis from loss of parasympathetic fibers from the cranial nerve 3. Horner syndrome, which includes ptosis, meiosis, and anhidrosis, may be present. The sensory exam might reveal diminished sensation to the face due to the compression of the ophthalmic and maxillary branches of the fifth cranial nerve, and impaired corneal reflex. The optimal diagnostic test is neuroimaging with either contrast-enhanced computer tomography or magnetic resonance imaging, or MRI, CT venogram or CTV, and contrast-enhanced MR venogram, MRV, are highly sensitive, whereas non-contrast CT and time-of-flight MRV may miss the diagnosis. Non-contrast CT of the head, although not ideal for a cavernous sinus thrombosis diagnosis, may reveal several subtle abnormalities such as engorgement or dilation of the superior and or inferior ophthalmic veins, bulging of the lateral margins of the cavernous sinus, exophthalmos, and possibly the presence of sphenoid or ethmoid sinusitis, or mass of lesion near the sphenoid or pituitary gland. Contrast-enhanced MRI brain shows the bulging of the cavernous sinus, increased dural enhancement, and absence or absent flow void in scene. CT and enhanced MRV can detect dilation of the cavernous sinus, enhancement and convexity of the lateral wall, which is normal concave on the coronal views, heterogeneous and asymmetric filling defects after contrast, increased density of orbital fat, thrombosis in the superior ophthalmic vein or veins, and tributaries leading to the cavernous sinus. Additionally, carotid artery neuron, carotid arterial wall enhancement, cerebral infarcts, intraparenchymal hemorrhages, empyema, meningitis, cerebritis, or abscess may be noted. As multiple thrombosis are common with this condition, dural venous sinuses and cerebral veins are to be evaluated carefully. Blood studies may be revealed evaluation in the white blood cells count or VBC, C-reactive protein, CRP, erythrocyte sedimentation rate or ESR, and D-dimer. Blood cultures should be obtained routinely and are frequently positive. Lumbar puncture is important to exclude meningitis and may show elevated opening pressure and pleocytosis even the culture-negative samples. Screening for thrombophilia may give false results during anticoagulation therapy and should be delayed until after treatment is completed. Because of the rarity of diagnosis, no randomized controlled trials are available and expert opinion guidance treatment. In general, antimicrobial and antithrombotic therapies are primary consideration. Antimicrobial therapy and let's look at this slide. Includes an anti-staphylococcal agent, vancomycin, or if methicillin resistant is high, or nafcillin. A third generation cephalosporin and metronidazole for anaerobic coverage, as well as antifungal therapy with amphotericin B. A prolonged duration of parenteral therapy, typically 3 to 4 weeks or at least 2 weeks beyond clinical resolution, is suggested. Most experts recommend anticoagulation in the absence of strong contraindications with either infractions heparin or low molecular weight heparin for several weeks to several months. And you can see it on this slide. Though not supported by prospective clinical trials in cavernous sinus thrombosis, retrospective reviews suggest a possible decrease in mortality from 40 to 14 with unfractionated heparin and the reduction in neurologic morbidity from 61 to 31% when anticoagulation is combined with antibiotics for septic cavernous sinus thrombosis. There does remain controversy with anticoagulation. The advantage would be to halt the progression of thrombosis, prevent clot propagation, and possibly allow penetration of antibiotics, whereas the risk would be systemic or intracranial bleeding or even dissemination of the septic emboli. Although cavernous sinus thrombosis differs from cerebrovenous and sinus thrombosis, the Cochrane collaboration suggests that anticoagulation for cerebrovenous and sinuses thrombosis appears safe even in the presence of intracranial hemorrhage and demonstrates a potentially important mortality reduction, though not satisfactorily significant. The European Federation of Neurological Societies recommends 3 months anticoagulation in secondary cerebrovenous and sinus thrombosis with the transition risk factor, 6 to 12 months for idiopathic cerebrovenous and sinus thrombosis, and those with mild thrombophilia and identify if subsequent cerebrovenous and sinus thrombosis or severe thrombophilia. As in cerebral, venous, and sinus thrombosis, there is inadequate evidence to support thrombolysis in cavernous sinus thrombosis. Corticosteroids are often given, but without demonstrated efficiency or efficacy. The potential benefit would be decreased inflammation and vasogenic edema surrounding cranial nerves and orbital structures. Steroids are necessary, however, for cases of hyperpituitarism. The international study of the cerebral veins and dural sinuses thrombosis reported steroid use in 24% of cerebral thrombosis with no evidence of improvement. No surgical interventions are recommended for the cavernous sinusitis or sinuses themselves. However, some patients might require sphenoidectomy, ethmoidectomy, maxillary antrostomy, mastoidectomy, abscess drainage, craniotomy, for example, if there is a subdural empyema, orbital decompression, or a ventricular shunt placement. Patients should be followed closely even after the discontinuation of their antibiotics. Differential diagnosis. The differential diagnosis includes other causes of cavernosus sinus syndrome and painful ophthalmoplegia. Cavernosus sinus syndrome can also be caused by local compression of the cavernosus sinus from non-infectious and non-thrombotic lesions, and 30% of which are tumors. And let's look at this slide, and you'll see carotid cavernous fistula with enhanced CT or MRI showing proptosis and large superior ophthalmic vein, dirty appearance of retroorbital fat, and enlarged extraocular muscles. Leaded bone lesions near the sphenoid sinus or sella turcica, tumors such as a metastatic cancer, meningioma, schwannoma, plexiforma, neurofibroma, pituitary adenoma, chondroma, and other tumors can occur, or even cavernous hemangioma can be found in case of some clinical features looks like cavernous sinus thrombosis. Meningioma, Sino-orbital aspergillosis, superior orbital fissure syndrome, Tolosa-Hunt syndrome involved a retroorbital granulomatous pseudotumor into the cavernous sinus, manifesting as a retroorbital pain, ophthalmoplegia, cranial nerve palsy, and clinical response to systemic steroids. Other causes of painful ophthalmoplegia include orbital apex syndrome, that is inflammation of posterior orbit, including the superior orbital fissure through which cranial nerves 3, 4, 5, and 6 and superior ophthalmic vein traverse, as well as optic canal involvement in the ophthalmic artery and optic nerve, and characterization by less edema and proptosis but more vision loss than cavernous sinus thrombosis. Orbital cellulitis, sarcoidosis, syphilis, tuberculosis. All these diseases can be diagnosed with cavernous sinus thrombosis, and as you see, a lot of difficulties with these complication, and these complication once more can be found due to some inflammation diseases in the maxillofacial area, beginning from some periapical lesion, maxillary odontogenic maxillary sinusitis, furunculus, carbunculus, abscessant, and cellulitis, purulent cellulitis of the face, especially endangered triangle. The next part of this lecture is erysipelas. Erysipelas is the skin infection involving the dermis layer of the skin, but it may also extend to the superficial cutaneous lymphatics. It is characterized by an area of erythema that is well demarcated, raised, and often affects the lower extremities, with the face being the second most commonly affected site. Erysipelas is also referred to as St. Anthony's fire due its intense fiery rash. Its diagnosis can overlap with cellulitis, and often a definitive diagnosis can be made. Cellulitis has ill-defined borders and is shown to develop, with erysipelas has better defined borders and faster development. Erysipelas can be serous but rarely fatal. It has a rapid and favorable response to antibiotics. Local complications are more common than systemic complications. The most common course is group A streptococci. So, the primary inciting infection involves streptococci, and most facial infections are due to group A streptococcus, while non-group A streptococcus involves more of the lower extremity. In the prospective study in Norway, researchers concluded that beta hemolytic streptococci were the leading cause of the facial cellulitis. In neonates, group B streptococcus is the leading cause of postpartum erysipelas. Erysipelas starts with the skin breaks uh, and leads to the inoculation of the eliciting bacteria. Surgical incision, insect bites, stasis ulcerations, and venous stasis are among the many entry portals. In addition, facial erysipelas may be caused by a recent infection in the nasopharynx passage. This is little responding evidence that Staphylococcus plays a role in erysipelas. Risk factors for erysipelas include the following: excising the saphenous vein for bypass, lymphatic edema, that is a major risk factor, lymphatic obstruction, arteriovenous fistula, status post-surgery, for example, mastectomy, or any other type of the surgery, and face surgery, oral surgery, nephrotic syndrome, and immunocompromised state. Most epidemiological studies of erysipelas have been done in different inpatient settings across different countries, and erysipelas can affect people of all age groups, races, and sex. Some studies show that erysipelas is most common in females. The incidence of erysipelas has decreased since the development of antibiotics and involved skin infection spreads through a break in the skin, directly invading the lymphatic system and causing erysipelas. Insect bites, stasis ulceration, surgical incisions, and venous insufficiency have been reported as portals of entry to the skin. Some risk factors that predispose people to develop erysipelas are obesity, lymphedema, athlete's foot, leg ulcers, eczema, intravenous drug abuse, poorly controlled diabetes, and liver disease. Recurrent erysipelas has been also reported, with the infection typically reoccurring in the same site. The histopathology will reveal significant vascular dilatation, dermal edema, and invasion of the bacteria into the lymphatics and connective tissue. Blood vessels invasions is rare. Erysipelas remains a clinical diagnosis, and assessing the patient for any recent skin trauma or pharyngitis is important. Patients often experience systemic symptoms such as malaise, fever, and chills 48 hours before the onset of the skin lesion. And let's see pictures. It has been well described that erysipelas presents as an area of the skin erythema that is sharply demarcated with the raised edges. Often patients with complain of the burning, tenderness, and itchiness at the site. More severe disease can present with vesicles, bullae, and even frank necrosis. The location of inflammation is very important. In the lower extremity, erysipelas is recommended to examine in interdigital toilet spaces for fissures, scaling, or maceration. Redness and swelling involving in joint should raise suspicion for the other more serious diseases like septic arthritis. And according to the face, you can see that the most common location of erysipelas, that is the nose and cheeks, but in some cases it can be spread to the forehead and even temporomandibular joints. So arthritis, rheumatoid arthritis, or other types of arthritis can be supposed if the beginning of site of erysipelas in that area. No laboratory workup is required for the diagnosis of this pathology. Leukocytosis, elevated ESR and C-reactive protein are common, but will not change the management of the treatment plan for the most otherwise healthy individuals. Blood cultures have a low yield and are not routinely obtained. However, consider blood work and culture in the immunocompromised, ill-appearing patient. Also, consider extensive workup in patients who may be intravenous drug abusers, patients with prosthetic heart valves, and those with other intravascular devices. Patients who are septic will require full workup and resuscitation. That should be clear. Antibiotics against streptococcus should be initiated when erysipelas is suspected. Penicillin as a monotherapy remains the first-line antibiotic used for the treatment of erysipelas. Coverage against MRSA is controversial, and the Infectious Disease Society of America in 2014 guidelines for the diagnosis and management of the skin and soft tissue infections recommended coverage against methicillin-resistant Staphylococcus aureus in patients whose cellulitis is associated with penetrating trauma, evidence of MRSA infection elsewhere, nasal colonization with MRSA, injection drug use, or SIRS. Most patients with erysipelas can be discharged home on oral antibiotics. The recommended duration of antibiotic therapy is 5 days, but the period may be extended to 10 days if the infection doesn't improve. Hospitalization is recommended for concern of necrotizing infection, the immunocompromised, the patient with poor adherence to the medications, and follow-up for those whose outpatient treatment is failing. A Cochrane review published in 2017 reviewed 5 trials assessing the prevention of recurrent episodes of cellulitis and erysipelas. They concluded that patients who were on preventive treatment with antibiotics, particularly penicillin, had the decreased risk of future episodes by 69%. In a retrospective study done in Prague, they have found the benzosine penicillin once every 3 weeks was effective prophylaxis for recurrent erysipelas. However, they could not conclude the needed appropriate duration of prophylaxis treatment. The 2014 practice guidelines for the diagnosis and management of skin and soft tissue infections recommended oral penicillin or erythromycin twice a day for 4 to 52 weeks or intramuscular benzardine penicillin every 2 to 4 weeks in patients who have 3 to 4 episodes of cellulitis per year, despite attempts to treat or control predisposing factors. And on this slide, I try to conclude what antibiotics, in what dosage, and how long can be prescribed for patients with episodes of erysipelas of the face. So we can use cefalexin or oral for 7 to 10 days, and usually adults and children 12 years and more we use 1 gram 2 times daily. Amoxicillin or clavulanic acid, coamoxicillin, the same per oral for 7 to 10 days. In sometimes we can prescribe injectionable antibiotics, intramuscular antibiotics. For intravenous, we need inpatient management for the patient, so usually we can prescribe or intramuscular or peroral. Other supportive treatments include hydration, cold compresses, acetaminophen for fever, and extremity elevation if these erysipelas on extremities. If there is evidence of an abscess or gangrene, surgical debridement is necessary. Admission is usually required for infants, elderly, and immunocompromised individuals. There are diseases that can mimic to erysipelas. This slide, all of which present with erythema, worms, edema, and pain. Some of the more serious diagnoses include septic bursitis, septic arthritis, necrotizing fasciitis, orbital cellulitis, deep vein thrombosis, phlegmasia, chorea dolens, flexor tensor synovitis, and toxic shock syndrome. Less serious diagnoses include cellulitis, abscess, fallen gout, and paranoia. Generally, the prognosis of erysipelas is good and can be managed in the outpatient setting. In the response well to the oral antibiotics, however, extra caution should be taken in the immunocompromised and those with poor adherence to the medication. Hospitalization for intravenous antibiotics is recommended in several cases, affecting those who are immunocompromised, infants, and elderly. Close monitoring and observation are also recommended for those who will most likely not comply with instructors or complete their antibiotics course secondary to the physiological or social reasons. Complications of erysipelas can be serious but rarely fatal. Some local complications include abscess formation, scarlet fever, pneumonia, meningitis, skin necrosis, hemorrhagic purpura, thrombophlebitis, and bullous formation. There has been a case report of erysipelas leading to the bilateral lower limb and abdominal elephantiasis secondary to erysipelas. A retrospective study of 152 cases of erysipelas evaluated for risk factors associated with local complications. They reported that prior empirical antibiotics and increased ESR at the time of the admission were independent risk factor for the development of the local complications of erysipelas. Local recurrences reported in 5 to 20% of patients and can lead to this scarring. Erysipelas is commonly encountered by the primary care provider and nurse practitioner. The diagnosis in most cases is clinical, but if there is any doubt, the patient should be referred to a dermatologist. The infection does respond to antibiotics, and patients are usually managed as outpatients. Hospitalization is recommended for concern of necrotizing infection or immunocompromised patients with poor adherence to the medications and follow-up, and for those whose outpatient treatment is failing. An infection, disease, or wound care nurse should follow these patients to ensure cure. Those who undergo surgery for an absence of gangrene may require long-term wound care. The pharmacist should encourage medication compliance. The team should communicate with each other to ensure that the patient is responding to therapy. The outcomes for patients with erysipelas are good as long as they remain compliant with antibiotic treatment. Okay, for today that is all. That is not such a big lecture as it was in previous cycles, and I hope everything is understandable. I try to prepare for you slides with text in order maybe you want to see it once more and do a conspect. Thank you for your attention. See you on our classes. Bye bye.